Hey there, welcome back for another week. We're going to talk about cardiomyopathy and heart failure and mechanical circulatory support this week. To start with, we will discuss cardiomyopathy. And there are, well, it seems like every week there's a new version of cardiomyopathy being added, but suffice it to say there are really three, and I'm going to talk about another one called Takotsubo Cardiomyopathy, but I'm not sure that it really classifies or really deserves to be grouped with these others. So first of all, dilated cardiomyopathy, or DCM, is oftentimes caused by coronary disease and MIs, and that leads to the primary problem in dilated cardiomyopathy, which is pump failure. That is, the squeeze of the heart is reduced, and therefore it's unable to meet the metabolic demands of the body. That's the definition of heart failure, right? So we see this following certain viral infections. We see it from toxins. We see it from long-standing hypertension. We can see it after pregnancy. But again, as I said, by and large, the most commonly encountered form is the ischemic form, where people have had MIs that cause the heart to not be able to meet the metabolic demand of the body because of the systolic impairment. HCM, or hypertrophic cardiomyopathy, is kind of the opposite of dilated cardiomyopathy. In this case, the squeeze of the heart is great. In fact, it's hyperdynamic. It squeezes too good. The problem is that it doesn't relax well. This diastolic dysfunction that you have in HCM means that the heart can't fill, and when it can't fill, it doesn't really get enough blood that it can send out to the rest of the body. So HCM is, in many instances, the opposite of dilated cardiomyopathy, but it still results in an inability of the heart to meet the metabolic demands of the body. Actually, this is the only disease I knew about when I left my first job, because at NIH, when I was working there, we had we had this HCM protocol, and we studied this disease, and it was very different than any of the other problems that we saw there. Restrictive cardiomyopathy, you probably will not see much. If you do, I'm willing to bet that it's going to be due to amyloid. Amyloidosis is a particular disorder that's an inability of the body to be able to process this abnormal protein called amyloid, and it builds up in the heart, builds up in the liver, other places in the body, and it results in this stiffening or this restriction of the heart muscle. Finally is Takotsubo Cardiomyopathy. There actually is another kind of cardiomyopathy that's not listed here called arrhythmogenic right ventricular cardiomyopathy. It's so rare that we're not going to bother talking about it. But Takotsubo Cardiomyopathy was just invented recently, like, I don't know, 10 years ago or so, 15 maybe. This used to be referred to as the catecholamine-induced cardiomyopathy, and then somebody decided that we should call it Takotsubo cardiomyopathy, which Takotsubo actually stands for, in Japanese, octopus trap, and it makes the ventricle look like an octopus trap, as you can see here in this systolic frame. So what happens is the apex of the heart in this case, and there are different forms of this, different patterns that happen, but the apex of the heart doesn't contract, and the basal walls do. The reason that's a problem is that you get this ballerina slipper here, where this the apex doesn't really work, but this part does, and that means that the blood goes halfway down here and halfway up here, out through the aorta. So this problem is associated with typically little, well, I shouldn't say that. It's often associated with people who have gone through a tremendous shock to their system. The death of a spouse, witnessing a murder, really incredibly awful things that happen to people where they have this major rush of adrenaline and their heart essentially doesn't know how to handle it. And so they have this major attack of heart failure, and they come into the emergency room and they look like they're having an MI, and their EKG looks like they're having an MI, and we take them to the cath lab and we shoot their coronaries, and their coronaries are totally normal, but they have this dramatic abnormality on their ventriculogram and in their echoes. And these patients seem to have responded poorly or adversely to the catecholamine surge that happened to them. These patients tend to be older patients. They tend to be women, and the majority of them actually get better from this. But there are, we're still studying this and trying to figure out what the long-term sequelae of this are. So cardiomyopathy clinical manifestations tend to be those that you associate with heart failure, right? So fatigue, peripheral edema, cough, particularly cough while laying down, or PND, orthopnea, dyspnea on exertion, all these things that you're accustomed to with heart failure are the things that you expect to see in cardiomyopathy. Because what is it that makes patients symptomatic from cardiomyopathy? It's their heart failure. So there are complications that happen with these patients. The complications can include sudden cardiac death. They can have arrhythmias, particularly in the hypertrophic population. They can have valvular problems. Mitral regurgitation is very common in dilated cardiomyopathy, for instance. They can have emboli that form when you have a severe reduced systolic function, as in dilated cardiomyopathy. The heart can move so poorly that the blood doesn't move efficiently, and clot can form in the apex of the heart. So these are all different complications that we see with cardiomyopathy. Treatments are aimed at heart failure. So the same things that you know about for heart failure are the things that we do for cardiomyopathy. So that should make it pretty easy for us to get through this, right? You know about ACE inhibitors and ARBs and the importance of them in reducing MIs. And in reducing heart failure, hospitalizations, and prolonging life. You know about the importance of diuretics to keep patients breathing well. DIG, we're kind of off the DIG kick right now. But in a few years, somebody will do another study that says that we never should have gotten rid of DIG, and it'll come back around again. Just stick around. Inotropes and vasopressors, beta blockers. We love beta blockers for all kinds of cardiomyopathy. And so these are the things that you are probably accustomed to seeing used for patients who have heart failure. And what's the biggest cause of heart failure, or what's a substantial cause of heart failure? Cardiomyopathy. So it all should make sense to you. We're also going to talk about mechanical circulatory support, that's MCS, and transplant very briefly, because those are important considerations for critical care nurses. So heart failure, as you know, is the inability of the heart to meet the metabolic demands of the body. There are any number of ways to divide up heart failure. It can be left-sided, can be right-sided, it can be backward failure, forward failure, there can be diastolic failure, systolic failure. There's many, many, many ways that we divide this up, depending on what the specifics are that we're considering. So when we're talking about the medicines that we need, we often differentiate between diastolic and systolic failure, right? Diastolic failure we treat by trying to help the ventricle relax, so we use medicines like verapamil, for instance. We never use verapamil in dilated cardiomyopathy because it'll make patients live less long, right? It'll kill them earlier. So there are very specific things that we have to do for each of the kind of cardiomyopathies that are out there. But you know the basics: beta blockers, ACE inhibitors, ARBs, diuretics. And if those things don't work, then we need to add, and spironolactone. I forgot to mention that one. That's a very important one. And then if those things don't work, then we need to add medicines to squeeze the heart more. And those are medicines like dobutamine and milrinone and things like that. So remember that the New York Heart Association heart failure classification system is class 1 through 4. Class 1 is no symptoms. They feel fine. They're not having any problems no matter how much exertion they do. Class 4 is dyspnea at rest, or with very little exertion whatsoever, even less than ADLs. I would say that Class 3 is really very limited ADL kind of symptoms, and most of our heart failure patients live in the 2 to 3 range, heart failure class 2 to 3. Now, this is different than the American Heart Association classification system. We're not going to bother with that one today. We're just going to stick to the NYHA, or the New York Heart Association classification system. So we talked already about causes of heart failure, but there are others, right? So cardiomyopathy is a big one that we see in critical care units, but we can also see renal failure, pulmonary diseases, valvular heart disease, dysrhythmias. These kind of things can all contribute to heart failure as well. So how does heart failure work, and how can we intervene? Well, if we start at the top, we see that heart failure begins and is due to a reduced cardiac output. When that reduced cardiac output happens, it causes renin to be excreted, and renin stimulates this whole process here, where the angiotensin 1 gets converted to angiotensin 2, which stimulates aldosterone, which means that everybody holds on to sodium and water, and that produces more cardiac remodeling and vasoconstriction results, sodium and water retention, as I mentioned, this sympathetic nervous system activation, and this whole downward spiral happens where it begets more heart failure. Notice that there are several places around here that we can intervene, right? So we can intervene with diuretics to affect the sodium and water retention. We can intervene with beta blockers to affect remodeling and to also affect the sympathetic nervous system. We can get ACE inhibitors and ARBs to affect this angiotensin and aldosterone system. We could use spironolactone to prevent the aldosterone from doing all of its terrible things, not the least of which is causing cardiac remodeling. There is this curious thing here, these renin inhibitors. I'll bet you don't know of any renin inhibitors, do you? Well, the reason you don't know any is that none of them have been approved for use by the FDA. So there are some renin inhibitors out there. Turns out they don't really benefit you any more than the ACE inhibitors and ARBs do already. So they really are our mainstay of therapy. So let's just review left-sided versus right-sided failure. This is one of the more helpful things for us to discuss. Remember that left-sided failure tends to cause the lungs problems, whereas right-sided failure, or cor pulmonale, tends to cause peripheral problems. So in left heart failure, we see a lot of patients with fatigue and tachycardia and orthopnea where they can't breathe when they're laying flat in bed. We see PND, or paroxysmal nocturnal dyspnea, where patients are sound asleep and then they wake up suddenly and they can't breathe and they sit on the side of the bed for about 20 minutes or so. Has to be 20 minutes, right? Can't be 2 minutes. Has to be about 20 minutes or so. And what happens during that intervening 20 minutes is that the body, the pressure in the lungs takes about 20 minutes to go back down again after the fluid has started leaking out into the interstitial space in the alveoli. And the patient sits up then, relieves that pressure, but it takes about 20 minutes for that fluid to unaccumulate from that interstitial space in the lungs. So when you hear PND, when you get that description, that is gold, because that is heart failure. Has to be. There's nothing else that causes PND. So that's a very useful thing to find. So coughing, all the pulmonary kind of stuff, left-sided failure. All the right-sided stuff tends to be weight gain, dependent edema, distended jugular veins, ascites, diarrhea. Those kind of things happen in right-sided heart failure. Okay, so left-sided heart failure, certainly more worrisome usually, and those are the ones that we tend to think about more often. So how do we make these diagnoses? Well, chest x-ray is very simple. It's a very easy way to make the diagnosis of heart failure. We can see the fluid leaking out in the tissue in the lungs, and we can see cardiomegaly, where the heart is bigger than 50% of the chest. So we use chest x-ray a lot. We use EKG a lot, although it doesn't necessarily help you know that patients are in heart failure. It can tell you that they're having dysrhythmias. One way that it can be helpful is if you have a patient who comes in and they say that they have cardiomyopathy, for instance, and you look at their 12-lead EKG and it's rock normal, the chances that they have a cardiomyopathy are pretty low. Right? So I've actually used that trick a few times when patients don't give a great history and it's kind of hard to piece everything together, but they've heard the word cardiomyopathy before. That tends to help us out if they have a rock normal EKG. Other diagnostic modalities, we can use a pulmonary artery catheter. We're going to talk about that in a couple of weeks, so I'm not going to belabor the point here, but some of the things that we can get from that are the cardiac output. We can assess their volume status as well, and then their peripheral vascular resistance and their oxygen consumption and all that stuff. Echocardiography, wonderful test. It's cheap, it's easy to do, nobody gets hurt, and it's done at the bedside with very little fanfare. We get great information from it, and if we can't see very well, then we can do a transesophageal echocardiogram where we do see really well. So those are useful things. And then, the lab tests that we get, basic metabolic panel, CBC, the B natriuretic peptide, LFTs, and lactate levels, those are all useful in later stage heart failure as well. So let's talk about the left ventricular ejection fraction, or LVEF. There's a lot to understand here. First of all, you have to know that this number is kind of made up, right? Like, there's no test that you do where you get a perfect assessment of somebody's ventricular function. Most of the tests are a visually estimated ejection fraction. So echo, for instance, we visually estimate that the contractility of the heart. Nuclear imaging, we can get a number that's calculated, and it's really the best that we can get, but we don't bother doing that except in rare instances. We usually do it with a stress test because we're already there. We already gave them the isotope, and it's easy to do. But a MUGA scan is really the nuclear test that we use to get an accurate number. Again, the echocardiogram is usually just visually estimated, and that's good enough for us. So then we apply these numbers to that. A normal ejection fraction is, and these numbers vary from center to center. So when I was in Philly, we were happy with a 50 to 55% ejection fraction. At the practice I'm at now in Chambersburg, they're very clear that they look for a 60 to 80% ejection fraction. I think that's a little generous. What I'm used to was a little less than that, but every center kind of has their own little numbers that they use. They are in this neighborhood, though, and we all agree that an ejection fraction less than 35% is severely reduced. Usually we agree that 35 to 45% is moderately reduced, and then mild is, 45 to 55, 45 to 60, 50 to 60, whatever, somewhere in that neighborhood. The other thing that I want you to know is that hyperdynamic is an important thing too. So when you have somebody who has HCM, for instance, or hypertrophic cardiomyopathy, when you have a hyperdynamic ventricle, that's important to know too. So if they have a 90% ejection fraction, that's really important information. So don't think that that a normal ventricle is just above 55. That's inaccurate. You can have an abnormal ejection fraction on the high side too, like a 90 or 100% ejection fraction. That's abnormal. What do we try to achieve for heart failure treatment? Well, many things, not the least of which is improving the pump function, right? So we try to get the pump to work more efficiently. The pump, I mean, being the left ventricle. We need to optimize fluid volume to do that. We need to make sure that tissue perfusion is adequate. But at the end of the day, what makes us do that sometimes is decreasing the workload and the O2 consumption of the heart. That's why we use beta blockers, right? So we love beta blockers, but if you think about it, it's reducing the myocardial contractility, reducing the ejection fraction, reducing the contractility, reducing the heart rate, reducing the blood pressure. Those don't all sound like they're useful things. Why would we want to make the heart squeeze less vigorously? Well, the reason is oxygen consumption. What we're really interested in at the end of the day is preserving the heart as much as we can and decreasing the oxygen consumption. All right. So that's really the mainstay of heart failure treatment. Sometimes, though, that's not efficient enough or not sufficient. And sometimes we have to squeeze the heart a little bit more. And sometimes we need big guns like mechanical circulatory support to meet those metabolic demands of the body. So remember, ACE inhibitor, ARB, beta blocker, diuretic, and the thing that is not included on here that should be is spironolactone. Very important. Oh, there it is. Other drugs. Spironolactone. Very, very important. DIG, not as important today. We're not big fans of it. Eplerenone, hydralazine, nitrates, these vasodilators, also important. We use ventilator support, and we do other kind of things for pulmonary hypertension that's causing right heart failure. But again, the real mainstay of treatment, ACE inhibitor or ARB, beta blocker, diuretic, aldactone. When we need to, when those things are ineffective, then we end up going to dobutamine or milrinone or dopamine or combinations thereof. Or sometimes we end up using Natricor. So Natricor is kind of a funny thing. When this drug came out, everybody was confused about it, but we had just gotten this test called the BNP, the B-natriuretic peptide. And we were told that when the BNP is high, that's bad. They're in heart failure, and so we should be concerned about that. And then they came out with this Natricor stuff and they said, hey, guess what? It's BNP. It's going to be great. Your patients are going to love it. Put them all on it. We're like, wait, I thought BNP was bad. Why are we giving them BNP? Well, if you take a step back and think about it, it makes sense, right? It's the body's production of BNP that we were measuring when we got when we got a BNP level. And what that was telling us was that the body was noticing that the atrium was stretched more, and that the atrium was stretched because there was an increase in volume. The body is the thing that produces the BNP. And so the theory went, if we take the body at its scientific best, we know that it's trying to help itself, right? So this BNP stuff, let's just wrap it up and package it and call it Natricor, and we'll actually administer it to patients and we'll see if that helps them. Well, in fact, it did. Not a whole lot. And we weren't really in love with the drug until a group of people came together. The pharmacologists came together and they combined it with valsartan and called it Entresto. And now actually it seems like Entresto may actually be a real benefit to these patients. So Entresto is Natricor plus valsartan, and that seems to be an important development in the treatment of heart failure. Another important thing that we use is nitric oxide, not nitrous oxide. That's the stuff that you get at the dentist office and makes you stoned and you can't drive home, right? Nitric oxide is what's released in by the vascular endothelium, and that causes relaxation of the vascular smooth muscle. And in heart failure, particularly in pulmonary hypertension, it reduces the vascular smooth muscle resistance and dilates the arterioles in the lungs. It's an important medicine that's very expensive to use. It has to be weaned off, not abruptly stopped, and it's dosed in ppm, parts per million. Flolan is this other medicine that we use that is prostacyclin, and this is also for pulmonary hypertension. It's used in a specific subset of patients, and it causes vascular dilation in the pulmonary bed as well. So what are the complications of heart failure? Well, I think you should know them already. We probably have talked about them in your other classes. Advanced heart failure, sudden death is a big thing. Pulmonary edema, cardiogenic shock. These are all things that can happen as a result of heart failure. So how do we treat heart failure after we exhaust the medicines that we have? Well, we can sometimes use dialysis. Sometimes we have to use that because the heart failure is so bad that the kidneys are failing. The other thing that we can do is mechanical circulatory support. And that can be done at the bedside. In many cases, they go to the cath lab to get the device put in, or maybe they need an LVAD and they have to put that in the operating room. Sometimes we use TA, or a total artificial heart. ECMO can be done at the bedside as well. And then this Impella device is kind of cool. We'll talk about those. Cardiac resynchronization therapy is important. As the heart weakens in dilated cardiomyopathy, the right and left ventricle get desynchronized. And when that happens, it's helpful to resynchronize those ventricles, and using a biventricular pacemaker helps to do that. They are combined with the functions of an AICD, and that helps patients to live longer. It prolongs life in end-stage heart failure. And then transplant is another potential treatment for heart failure, although there are very, very few hearts available. And if there's anything that's abnormal about you other than your heart failure, such as your body size, if you're really large or really small, it may be very, very difficult to find a heart for you. So those patients often end up with a destination device like an LVAD, for instance. So the cardiac resynchronization therapy that we talked about, essentially it's an AICD with a third lead. And so you have a defibrillator, and then we put in two leads. One goes into the RV apex, like you can see here. And then another one goes in right here where you can see into the coronary sinus, and it wraps around the back of the heart and then comes down here somewhere at a coronary vein. And that goes to the apex as far as they can get it. It's a tiny little lead. You can hardly even see it on chest x-ray. And then they pace the right and left ventricle sort of simultaneously. Again, everybody who gets a cardiac resynchronization device also has the AICD component, which is the defibrillator part. All right. So there's an animation for you to watch here, but essentially this prevents patients from dying from tachyarrhythmias. The other cool thing is that in addition to the AICD, every time you get an AICD, it also has the bradycardia or the pacemaker functions as well that can prevent your heart from going too slow. So the simplest of all these devices, which by the way is not all that simple, right? But the simplest of all the devices is a dual chamber pacemaker. And then if you need it because of heart failure, you can get an AICD to prevent you from having sudden death. And then if your heart failure is severe enough, you can get the top of the line device. And that top of the line device is a biventricular pacemaker that paces both the ventricles. There is this thing called a Lifevest. It sounds cool. So here's the deal. There's a 6-month period where you don't really qualify for a device after an MI, because maybe that'll go away and we won't need to spend $25,000 on giving you a new device, or $35,000 or whatever. So when that happens, there needs to be some way that we can prevent you from having sudden death in that 6-month interim period. Well, this enterprising company came up with this thing called a Lifevest, where they essentially have a defibrillator that's sewn into this vest that you wear all the time. Sounds great. But turns out the studies that just came out within the past year or so were not very favorable for this device. Of course, it has to be worn, it has to be fitted properly. And if you happen to be in the shower when the device, when you have an arrhythmia, then you're not wearing the device and it doesn't work. And so for these patients, it's just not been shown to be as life-saving as we had hoped it would. So what sort of things do we as nurses do for the patients with heart failure in the ICU? Well, they're busy patients. Believe me, there's a lot for us to do. We have to continually monitor them and assess them for their heart failure symptoms. We typically have to have the head of the bed raised so that they can breathe better. We get them out to the chair and up as much as we can, because beds are a terrible place for people to be when they're sick. That's where people end up dying, right? They get skin breakdown, they get pneumonia, they get other infections, and that's not a good thing. So get your patients out of bed as much as you can. Monitoring of hemodynamics continuously, and daily weights are very important. I's and O's are notoriously awful in the hospital. I don't care who's doing them. They are notoriously wrong. And the best thing to follow in the hospital is daily weights. And so we definitely follow daily weights, and I don't even bother looking at the I's and O's very often. I'm more interested in the daily weights, and hopefully they tend to correlate, right? Whole host of things for you to be monitoring in your patients who are in the ICU with heart failure. We do quite a bit of patient teaching with heart failure, and you can always throw a little bit of patient teaching in with your patients, making sure that they understand what it is that you're looking for, so that they'll be able to do it when they go home, and include the family in that teaching as well. And these are some of the things that we like to emphasize during those teaching sessions. Lifestyle modifications are important for people with heart failure. Although there has never really been a study that shows that sodium reduction is dramatically beneficial in treating heart failure, I think if you talk to any heart failure nurse in the whole world, they would say it definitely is important. And so we do teach our patients about that. We also want patients not to take alcohol in. When you have reduced LV systolic function and you drink alcohol, you simply are worsening your heart muscle function. We know that alcohol is a poison to the heart, and we don't want patients doing it, particularly if they have a history of alcohol abuse. That's just adding to the problem. And in fact, alcohol is often a cause of dilated cardiomyopathy. So keep that in mind. Stress reduction, exercise regime, maintaining a healthy weight. Those are all important things. Now, listen as I tell you that sounded weird, didn't it? Listen as I tell you. Sorry. So pay attention to this, though. The daily weight thing. Here's the rule when patients are being weighed all the time. If the patient, this is home rules, right? If the patient gains 2 pounds overnight or 5 pounds during the course of a week, we need to address that problem. And we want the patient to call us, or if they're in the hospital, we will adjust their medicines then. Again, 2 pound weight gain overnight, 5 pound weight gain during the course of a week. Those are the criteria that we use for worrying more about their heart failure. So let's talk about cardiogenic shock. Now, essentially, cardiogenic shock is heart failure that happens as a result of pump failure, right? So heart failure, remember, is the inability of the heart to meet the metabolic demands of the body. You've learned that. But now we're going to say that heart failure happens as a result directly of the failure of the heart as a pump. Okay? So it might sound like it's the same exact thing, but it's actually a little different. Shock is really an issue of perfusion. So there are different things that can affect perfusion, and we're going to talk about shock later, but I do want to talk about cardiogenic shock today because this is important for understanding why we use mechanical circulatory support, for instance. The causes of cardiogenic shock are very often an MI. Right? So somebody comes into the emergency room late into their heart attack, several hours into their heart attack, and they're in pulmonary edema, and they can't really get out of heart failure with all the things that we're doing. And so we need to intervene somehow. There are other things that can impair cardiac output, like cardiac tamponade, tension pneumothorax, pulmonary embolism, aortic dissection, things like that. But very often it is an acute ischemic event that is responsible for cardiogenic shock. So cardiogenic shock has very much the same kind of, I don't even know what to call this. the same sort of flow diagram as we talked about before, where it involves the renin-angiotensin-aldosterone system. It includes the fact that there's this catecholamine response to try to increase the preload, stroke volume, and heart rate, which actually is not really good for the heart, right? It might be good for the body for a short time, but it's not good for the heart because that increases the oxygen requirements of the heart. And when that happens, over time, the heart will fail more, and then you get decreased cardiac output, decreased ejection fraction, falling blood pressure, worsening tissue perfusion, which begets more ischemia, and then we have impaired cellular metabolism and worsening myocardial dysfunction, and that is cardiogenic shock. So the manifestations of cardiogenic shock are decreased cardiac output in index and a decreased SVO2. We're going to talk about those things more when we talk about shock in a couple of weeks. Actually, I think it's next week that we talk about hemodynamics, and we'll talk more about what all those things mean at that time. We see things like increased right-sided pressures, right atrial or CVP pressures. The pulmonary artery pressure can also be elevated. The pulmonary artery wedge pressure, or the wedge, is elevated, but that's actually a left atrial pressure, we will learn. And there's an increase in the systemic vascular resistance. Those things happen. Along with it happens the symptoms of right-sided heart failure, JVD, edema, hepatomegaly, and symptoms of left-sided heart failure, which are S3, crackles in the bases or wherever, whatever dependent position the lungs are in, hypoxemia, decreased urinary output, pale, cool skin, an altered level of consciousness. All of those things are what we see in cardiogenic shock. So how do we treat it? Well, first thing we have to do is try and get the heart working more vigorously again. But we also would like to do that by decrease and simultaneously decrease myocardial oxygen demand. Well, how can you possibly increase myocardial contractility, make the heart work harder, and simultaneously decrease the oxygen demand? It doesn't make any sense, right? Well, actually it does, and that's where some of our little toys come in. Toys like the balloon pump, toys like the Impella device, and toys like VADs and ECMO and things like that. So we're going to talk about some of these things, but there's other ways that we can intervene too. Remember PCI, or percutaneous coronary intervention, like stents and angioplasty and things like that. We can do for MIs. We can do emergent cabbage sometimes, although it's pretty hard to get a surgeon to take somebody in cardiogenic shock to the operating room because the outcomes are usually not good. We use medicines that reduce preload, such as diuretics. So think of preload as volume. What are we going to do to decrease volume? Well, we'll put them on a Bumex or Lasix strip. We can use other diuretics, but really the loop diuretics are the mainstay. We can also use balanced vasodilators like nitroglycerin or nitroprusside or morphine. I actually had a patient, one of the first patients I ever took care of as a nurse, when I worked in the emergency room. I was moonlighting in the emergency room when I was a new nurse. And we had a woman come in with pulmonary edema who had end-stage breast cancer, and she came in and didn't want anything done, but she just wanted to feel better breathing. So we gave her some diuretic, and we gave her a big dose of morphine to make her as comfortable as we could. And we sent her upstairs, and I thought that, when I went back a couple of days later to see her, I thought that she probably would have passed away. But I found one of the nurses who I knew on the oncology unit, and I said, so how did, Mrs. whatever do? And, kind of thinking that I would get a response, like that she was comfortable at the end or whatever. Turns out the nurse said, oh my God, she went home. She got better and went home. I said, really? What happened? Well, it turns out that morphine really did the trick. It reduced her preload to such an extent that she got out of heart failure and was able to go home. So never underestimate the power of morphine, but also don't overestimate it, right? All right. We also like afterload reduction, and there's nothing better for afterload reduction than one of the toys that we're going to talk about soon. But before we get to that, we like nitroglycerin drips for that, and milrinone or dobutamine drips can be useful as afterload reducers. In fact, it is really the afterload reduction that is responsible for a big part of the improvement in cardiac output with vasopressors like milrinone and like dobutamine. We'll talk about them more. The other thing we can do then is increase contractility, and as I said, these inotropes like dobutamine, milrinone, also epi and dopamine are helpful in increasing the contractility. Although this does not decrease the myocardial oxygen demand at all, right? This is the opposite. We're squeezing the heart. We're trying to make it work harder, and so that can be deleterious as well. The biggest complication of cardiogenic shock is multi-organ dysfunction. And when we see MODS, multi-organ dysfunction syndrome, when we see it affect more than 5 body systems, the mortality rate is 100%. So, when we get to MODS, that's a very bad thing. The mortality rate for cardiogenic shock by itself is 50 to 60%. So let's talk about mechanical circulatory support. MCS is any temporary or permanent means to intervene to increase the cardiac output to replace the action of a failing heart or lungs or both. Okay. And we have lots of devices that we can use. There is no shortage of what's being developed here. Now at Penn State, you should know that actually, 25 years ago, 30 years ago, Penn State was one of the centers in the world that pioneered these mechanical circulatory devices. The Penn State Heart, if you walk through the Hershey Medical Center in the north entrance lobby, you'll see a little display case on the right-hand side as you walk down the hall of a woman in a white lab coat standing out in the field, holding a line attached to a cow. And in the side of the cow is a metal door. And that metal door actually went right into the cow's chest, and that's where the artificial heart was. And so we have quite a bit of experience at Penn State Hershey with those devices over the years. So this can be a bridge to recovery, a bridge to transplant, or oftentimes some of these devices like the LVAD can be a destination therapy in and of their own right. And that means that the patient will live the rest of their life with that LVAD. Again, they were often developed as just bridges, but sometimes they become destination devices. So let's talk about the intra-aortic balloon pump. This is one of the oldest tools around. It's a very cool thing, and essentially it involves putting a catheter with a large balloon on it into the aorta through the femoral artery, and when that device is in the aorta, it is timed with this console here to augment the pressure. and we augment it in a positive way by inflating the balloon, and we augment it in a negative way, meaning we decrease the pressure in diastole using the deflation of the balloon. So let me help you understand this. First of all, the indication for this device is left ventricular failure, right? And we use this for cardiogenic shock, acute problems, that is. We use this pretty frequently. We tend to use it in acute MIs. We oftentimes put this device in the cath lab, and we use it to support the patient before they go for bypass surgery. It's a very easy to use tool. It's very powerful in reducing afterload, but it doesn't do much more than reducing afterload. So if you can get the patient by and support them with this a little bit, that's useful. There are other things that have come out more recently that are more powerful than the balloon pump, but this is a pretty easy thing to do in the cath lab, and you should know how to do it. There are contraindications to using it. One of them is aortic insufficiency. So if there's leaking of the aortic valve, this can't be used. Also, an aortic aneurysm is an absolute contraindication to it. Because of the size of the catheter that we use, coagulopathies are a problem. And if there's a ton of atherosclerosis in the aorta, having the balloon pump pound up against the blockages and the atheromas is not really a healthy thing to do. Everybody who you will talk to will try and convince you that the way that the balloon pump works is by increasing the amount of flow into the coronary arteries. That is just not the case. Without a doubt, the most important thing that a balloon pump does is decreases afterload, and therefore it decreases myocardial oxygen consumption. And the way it does it is this. We put the balloon pump in, and then we set the device and we time the device so that when the aortic pressure starts to come down and the aortic valve closes, that's when you get that dicrotic notch, remember? When you get to the dicrotic notch, then we inflate the balloon, and then it inflates, and as it deflates, then we lower the blood pressure as low as we can get it. All right. So normally the pressure would come down to here, but the diastolic unloading, right, at the end of diastole, this unloading that happens, or this reduction of the diastolic blood pressure, is even more important. This is the end of diastole, right? Right before the systole happens. That's the end of diastole. I'm not sure why they're calling it systolic unloading. This is diastolic unloading for sure. Okay, does that make sense? So the balloon pump goes in. We inflate the balloon when the aortic pressure begins to come down at the dicrotic notch. Then we inflate the balloon, and then it's inflated for a fraction of a second while and then the pressure is released in the balloon, and the diastolic pressure goes way down. It's this diastolic unloading of the ventricle that really helps more than anything else. And it's not the forcing the blood down to the coronaries that does much at all. It is really the unloading of the ventricle that is the way that this works. Okay. So what do you need to do if you're the nurse? Well, you assist with the insertion, of course, and then we have to measure this timing every 4 hours or whatever the standard is for that unit that you're working in, and make sure that you take good care of this site. make sure that the sutures are there, that there's no drainage coming out, that the dressing is intact, and that the vessel isn't bleeding. Make sure that you have the helium level in the balloon pump adequate for the balloon to keep working. So helium, you might be wondering why we're using helium. Well, we would use hydrogen, except that, the Hindenburg and all that stuff. But why would we use helium or hydrogen? Well, because they're the lightest gases, right? It takes less effort to move those. So we can move them a whole lot faster than we can move room air. And helium is almost as light as hydrogen. And so it can move back and forth in that balloon very rapidly, and we don't have to worry about it causing any mischief. That's why we use helium. So there's a little brown gas bottle in there, and that has to be filled. And the balloon pump's all set and ready to go when you pull it out and start using it. This device goes in through the groin, through the femoral artery, usually the right femoral artery, sometimes the left. And when it's in there, we have to make sure that the patient, that the leg is straight. There's no hip flexion. And we certainly don't want to raise the bed past 30 degrees. We have to make sure that the balloon pump is properly positioned. This marker on the balloon pump actually tells us where the tip of the catheter is, and we want this to be at about the second intercostal space. So in fact, this one is just about right. So here's the first intercostal space. This is the second intercostal space because this is the clavicle, right? So this is the first intercostal space. This is the second intercostal space, and we want that balloon marker to be right there, right in the second intercostal space. You can see the aorta is right here. So it's right at the top of the aorta, where it's going to give us the best, the best function. Okay. Balloon pump complications. Well, you can imagine that thrombocytopenia is a problem, right? So as we bang the balloon up against the walls of the vessel, that can have an effect on the red cells. So you can have anemia because the red cells are getting destroyed. You can have thrombocytes getting destroyed as well. Because these patients have to be heparinized, you can also have heparin-induced thrombocytopenia. Limb perfusion can be an issue because you have a fairly decent-sized catheter in the groin that is taking up space and preventing full perfusion of the lower extremity. Skin breakdown, anxiety, potential for an embolism. So if there's clot that forms around this balloon or anywhere else, then that can embolize distally and cause problems. It's not unheard of that there's an aortic dissection that happens as a result of this. I've never seen it, but it is certainly a theoretical possibility. Balloon rupture is a real thing too. When you have the device in, if you see blood come out from the catheter in the groin, then or into the air line, that's moving the helium back and forth, then you have to turn off the device right away. It has to get pulled out, and you have to get a physician to come and take it out, because that balloon rupture obviously is, you can't continue to use it because you don't want to pump air directly into the aorta. I think that would be bad. Okay. One of the newer devices now is this thing called an Impella. Now this is cool. This actually can do 90% of the work of the ventricle, so that the ventricle can hardly be moving at all, and you can still have a perfectly normal blood pressure. This is actually really emboldened cardiologists to do incredible procedures like doing angioplasty and stenting of unprotected left main coronary arteries that was unheard of before this device came out. So here's what happens. The device goes into the ventricle, and there's a pigtail catheter here. So poke a hole through the ventricle wall. And at the end of the catheter, the blood gets sucked into it, and then it goes up the catheter and gets ejected out here in the aorta. And there's a little device that spins to accelerate the blood. And again, it sucks it out of the ventricle, shoots it up in the catheter, and ejects it into the aorta here. And that can provide a huge amount of blood flow and support for the heart. So easy to put in the cath lab. Takes a fairly decent size groin catheter, but we're good at that in the cath lab, and you get the device in there, and this is a very powerful way to support the patient. Now, it used to be only until recently that this device was only indicated in the cath lab for support of this patient during the procedure. More recently, at the American College of Cardiology meeting last year that I went to, they actually released the new study that says that they can actually use this. I believe it's for up to 2 weeks for left ventricular support in the ICU. The next device is the LVAD. This is a big deal, right? So these other two devices can be put in emergently, and there's no problem doing that. And they're easy to do for experienced clinicians. They can put those devices in the cath lab. The LVAD, this is a planned thing. This is not something done emergently. This is something that requires an awful lot of planning and consultation, and patients have to be seen by the psych service to make sure that they understand all of the implications for this. There are major implications for lifestyle with these devices. And the idea, as I said, used to be that they would have this device put in as a bridge to transplant. And then when the transplant became available, then this would be explanted and they would get their new heart. And then they would live happily ever after, right? Well, it turns out, since there are so few hearts available, that this has become a destination device for patients. And there are many patients who live the rest of their lives with this device. The negatives are that you have to be hooked up to this battery all the time, right? The battery has to be charged. You also need to make sure that you have the battery packs with you if you're traveling anywhere. So it's a big deal from that perspective. There's also potential for driveline infections. So you can see here where this white line stops and turns to this grayish color. That's going through the skin, and then it goes into the body and goes right to the device that's implanted in the ventricular apex. The other issue, so this drive line can become infected. That's a big problem. The other issue is that when this blood goes through this foreign body, essentially, and the blood goes here and then is shot up through and into the aorta, very similar to an Impella device, only at a much higher volume. When this blood goes through here, there's a potential for clot to form. And if a clot gets formed in here and goes to the aorta, one of the first places it can go is up through the carotid arteries here, or the cephalic artery. The brachiocephalic artery to the brain. I have to rephrase that because that made no sense, right? So it can go up the carotid artery or the brachiocephalic artery. If it goes up the carotids, then that's when it goes to the brain, right? That would cause a problem. So stroke is a big issue with LVADs. This is an LVAD that's been implanted into the patient. You can see that he had the median sternotomy incision. The device was implanted here. He has a mediastinal chest tube. Here is the drive line that is coming out, and it's hooked up here to the little computer that is adjusted for the device. Here's the drive line again in another patient that's coming out, and it's attached to the belly here so that it can't move and go anywhere. This is the HeartMate device. This is the control center for the device itself. You can see there are several manufacturers, the Thoratec device here, the HeartMate device here, and then the monitor that you see for the Heartwear device in the ICU looks like this, and it has three important numbers on it. It has the liters per minute of flow, the revolutions per minute, how fast that impeller device inside is spinning, not to be confused with the Impella device that is put in the cath lab, but the impeller, which is like a little propeller that spins to move the blood. That's the speed that it's set at. And the physicians adjust this based on how the patient's doing. And then last is the watts, or the amount of energy that's being used. The next device that we see used is a BiVAD, or biventricular assist device. And this is so that we can support both the right heart and the left heart. These are pretty uncommonly seen, right? So it's a complicated thing. I don't want to get into it too much, but essentially the LVAD is very useful for patients who have normal right heart function, who have normal pulmonary artery pressures. When the pulmonary pressures are high, it makes it very, very hard to use an RVAD, and this patient certainly can't survive with just an LVAD. They also need right ventricular support. But when the pressures in the pulmonary arteries are high, it's really hard to get the RVAD to work and to support the heart well enough. Sometimes these patients who have bad pulmonary hypertension don't have a lot of options. But if a patient has normal pulmonary pressures and they had, say, a right ventricular MI, then an RVAD can be useful, right? So we don't have these huge pressures that we have to work against. We just have to move the blood. And so the RVAD can be used to move the blood into the pulmonary artery, and then it goes and works with the left ventricular assist device as well. The interesting thing about LVADs is that these patients don't have a palpable blood pressure, right? They don't have a pulse because they don't have pulsatile flow. It's just constant flow from this little impeller or propeller in here that's propelling the blood through the system and out into the aorta. There's no pulse here. The heart doesn't beat. So, the heart does beat, but the majority of the blood is being moved by this device, and so there really is no pulsatile flow. So we monitor the arterial pressure as the mean, and we do that with a Doppler device. There's a little video here for you to watch, and I'll let you do that on your own. The PVAD is a biventricular assist device that is implanted for the short term in the ICU. And this is not a destination device, as you can see. This is really a temporizing device. And there are other different kinds of PVADs that are available out there. This is one of them. There's another one by Thoratec where it actually goes, where it's more internalized than this. But there are different devices that are used to support failing ventricles. The thing that you'll see the most at Hershey anyway, and in many ICUs nowadays, is this short-term device of ECMO, or extracorporeal membrane oxygenation. There are two kinds of ECMO. There are veno-arterial, or VA ECMO, which is essentially cardiopulmonary bypass, and veno-venous ECMO, which is essentially just replacing the lungs, right? So VA ECMO can support the cardiac output and oxygenate the blood, VV ECMO is just to oxygenate the blood, and the heart's doing all the work. So it's useful. The indications for each are different. This is what a heart-lung machine looks like during open heart surgery. And yet, we're able to do all of that with this little device called ECMO. So VA ECMO is used for cardiogenic shock, cardiac arrest, after transplant, if there's problems getting people off the pump, off the heart-lung machine, we can use ECMO for a short time. And then it's also a bridge to LVAD in patients who have a failing heart and need it. So the way this device works is that we put in the VC, or the venous cannula, and that venous cannula goes into the femoral vein here. And then we have the arterial cannula that goes into the femoral artery. And those devices then are hooked up to the ECMO device, and it pulls out the venous blood, and the blood is oxygenated and propelled through the arterial sheath back into the systemic circulation. This is what it looks like in real life. You can see the console here where we monitor the RPMs, or the flow rate, and then the liters per minute are noted here. And this is the motor that's hooked up here. And in the motor is where the blood comes and gets sent back to the body then. Okay. VV ECMO is really just for respiratory failure, or ARDS, or some sort of pulmonary failure, maybe after a failed lung transplant, or if there's severe trauma that impacts the ability of the lungs to work. But essentially, this can usually be done through just the subclavian vein, or the jugular vein, and that goes right, in this case, goes down into the jugular vein and pulls out venous blood, and the blood goes to the machine, to the ECMO machine, gets oxygenated, and then it comes back to the same vein again, where it gets distributed to the heart and goes to the rest of the body then. These patients, it's nice to see somebody who's up and about. The nurses want to get these patients up and out of bed as much as possible, and it is possible to do this, but you really got to be careful about this. You can see he has a headband on to hold this thing and prevent it from coming loose, and the nurse is very actively holding on to this line so that it doesn't fly out. You can see the darker blood in this one compared to the arterial blood. The oxygenated blood. It's both going back into the vein, obviously, but you can see the difference in the color there. This is another patient who is up and about, and you can see her lines coming out from behind her head as well. So ECMO considerations for the nurse. This is always a one-to-one assignment, and sometimes there's two nurses assigned to one patient, particularly when they're getting the ECMO going and early in the post-ECMO phase. It's a very, very busy patient. So you may have a perfusionist there who's helping. That would be a great help, or the nurse is managing it if you're in a unit that happens. There's obviously hourly charting of everything, and even more frequent than that. The ECMO cannulas have to be monitored continuously. Make sure that the device is plugged into the red outlets, right? The red outlets in the ICU or anywhere in the hospital are the ones that are hooked up to the generator, so that there's no potential for loss of electricity. These devices, the dressings have to be changed regularly, and they're all sutured in, of course. And so there's a lot for the nurse to learn that you'll learn during orientation and the critical care course. So in this little oxygenator here that you can see, this little diamond shaped thing, or square thing, I guess. If you look at it straight up and down, it's a diamond, right? But if you look at this device, it's clear, and you can see if there's clot forming inside this device. And, you know, over a period of time, there will be clot that forms in there. So you have to just keep a lookout for that. Vascular checks are important. When you have the VA ECMO in particular, and that arterial line is in the groin, there's actually it's pretty ingenious, actually. They do have part of the arterial blood that is redirected through the catheter that goes down to the distal extremity, and part of the blood, the majority of the blood, then goes up toward the to the patient's vital organs. But that catheter is designed in such a way that they can actually preserve the flow to the distal extremity, because that catheter takes up the entire artery. You know, it's a huge catheter. Another important thing is the PTT. So sometimes when we have patients on massive doses of heparin, we don't use a PTT. That's not as useful as because it stops working, that particular test. We have to go to the ACT, or the activated clotting time. So you have to know, you know, if it's if they're on ECMO, it's usually the PTT that we're monitoring. But on cardiopulmonary bypass, for instance, in the operating room, and sometimes immediately after the procedure, we're using ACT to determine how anticoagulated somebody is. There is turning that has to happen, because your patient's skin is just as likely to break down, right? So if there's a do not turn order, then you need to find a way to offload the patient from the, from pressure points. And that's something that will be spelled out in the policy and procedures for your particular unit. It's also important that you always have a backup circuit and pump available, just in case one of them, the one that your patient is on, fails. You have to have it ready to go at an instant's notice. The last thing here is the total artificial heart, or the TAA. The TAA replaces everything. The ventricles are taken out. The atria are all that's left, and the device is actually sewn directly to the right and left atria. And this then becomes the functioning heart, essentially. You can see that this is a patient who has the device and has this little backpack thing. These backpacks have to be with the patient at all times. They make a horrible noise. That I'm sure is very comforting to the patient who has it, but it is a loud device that is running 24/7 and doing the work of the heart for the patient. It's an incredible thing. I've seen a couple of patients who have these devices, and unfortunately they end up living in the hospital for quite a long time in many cases. This is a patient who actually was able to go home, and that was wonderful. But all too often we see these patients remaining in the hospital for an extended period. So what are the complications of MCS? Well, the same kind of things that we talked about before, right? Emboli, neurologic events like strokes from thrombus formation, and those are particularly bad things. Anytime that we have a mechanical device that's mashing around inside the blood, we can have hemolysis that happens and thrombocytopenia. So those things need to be monitored continuously. Infection is a major problem. Here's an erosion through the abdominal wall from this drive line that you can see. These are, they're things that happen, unfortunately, and they can be potentially devastating. But at the same time, this is a life-prolonging procedure, and patients are often just very, very glad that they got any extra time after they've been through so much with their heart failure to begin with. Particularly with a TA, the battery life is critical, right? In fact, the TA only works, you only have a pulse or you're only alert when there's battery power, right? So power is life. With the TA, patients are not allowed to change their own batteries, right? Because if something happens and they drop the battery or something like that, they only have, a second or two before they'll lose consciousness, right? It's kind of weird to think about, but that's absolutely true. These patients all have to be anticoagulated forever, and you can imagine that that's a major issue to contend with when they have, some weirdo GI bleed that happens, or they have a nosebleed that can't be stopped, or any number of other things. It's also important, as the nurse taking care of these patients, that you know how to code your patient based on their device. CPR doesn't work for a TA, right? And CPR can be detrimental for an LVAD. You can really cause mischief in there. So you have to know how to code your patient depending on the device that they have. You have to make sure that you do peripheral vascular checks on extremities for ECMO in particular. But any device that is going into a vessel, make sure that the distal circulation is intact as well. Monitoring those lines and tubing, making sure that you're following the hospital protocol and your unit's policy and procedure manual for documentation, and then maintaining the arterial line monitoring as you need to. Remember to always have a backup device for these TAs in particular, and any other device like an Impella or balloon pump. Any of those, you need to have a backup console available at any time.